Hello, everyone, and welcome to today's webinar, The Value of a Venous Blood Gas in the Emergent Patient. I am Cassie Soltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Radiometer. To learn more, visit www.radiometeramerica.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Also, if you experience any technical issues, you can utilize this Q&A box and we will assist you directly. I'd like to now welcome our speaker, Kate Hopper, Professor of Small Animal Emergency and Critical Care at the University of California, Davis School of Veterinary Medicine. Kate, you may now begin your presentation.
Thank you, Cassie, for that introduction, and welcome everyone. I'm excited to share with you what I think is some of the values that we see in venous blood gas. I don't think I could do the job that I do without this tool. So my aim here is there's a lot of information we could cover. We're not going to do everything, but I've just picked a few highlights that I hope demonstrate the value. I have no conflicts of interest to declare. So when we're dealing with, urgent or emergent care of cats and dogs, the challenge is that sick animals all look pretty much the same. They have, huge variety of potential disease mechanisms that could be going on. And we're expected to work that out and start the appropriate treatment. And yet, from the outset, they don't always give us a lot of information. And so I think any diagnostic tool that we can get in a short period of time and that's practical in the emergency room setting is invaluable. And I really see the venous blood gas as one of those invaluable tools. The blood gas sort of by definition means that you're using a machine that can measure carbon dioxide partial pressure and oxygen partial pressure, so that the gases. Nowadays with the new blood gas machines, you're going to get a variety of data. What you actually get will depend on the machine you use. I think pretty well all of them are going to give you acid-base parameters. You often get electrolytes, you get blood glucose and lactate, and potentially a measure of renal function, creatinine and or BUN. And then some of them have co-oximeters and give you values for hemoglobin concentration and abnormal hemoglobin. So I think an incredible amount of information. And I think the piece for me that makes them invaluable is this is off a tiny sample of blood and you get your results in the matter of minutes. And I think that's the piece that I just, cannot move past. Like with that, I feel like, the understanding of what's going on with a patient and recognizing life-threatening abnormalities between a triage evaluation and a blood gas, I think, we really have most animals on track, within minutes of arrival. Before we talk about individual parameters, I did just want to mention the actual gaining blood samples, because in some situations we're going to use venous blood gas analysis on multiple serial blood gases. So some of these animals might receive blood testing every few hours, and so a lot of repeated sampling, and so anything we can do to avoid direct venipuncture for the comfort of the patient, as well as not wasting or damaging veins we don't have to, I think is valuable. And so we rely heavily on catheter aspirated samples. I'm making, I would say 90% of the blood we run in our emergency room and in the intensive care unit is aspirated from a catheter, and very often that's an everyday peripheral catheter. These are not fancy central catheters. And so I think just wanted to encourage anyone, if you're not doing catheter aspirated samples, is that before we ever do a venipuncture, we check if we can get that sample from the catheter. And that picture on the right is a little dog with a 22 gauge cephalic, and then you can see where it's aspirating like a champ. So really nice for patient care. It also often means one person can get that sample. You don't need two for the venipuncture. To do catheter aspirated samples, though, it is important to use a methodology that you ensure your sample is not diluted by the fluid that's sitting in the catheter, so that you get an accurate sample. And so there's two classic techniques that are described to do catheter sample aspiration. There's a push-pull technique, or this 3-syringe technique, and we tend to use the 3-syringe technique. So I just wanted to briefly share that. It really needs, you'll be shocked to hear, 3 syringes. So we have a 3 ml syringe on the far left there that has some heparinized saline in it, because we're going to aspirate a blood sample in that, and we want to anticoagulate that blood so that we can return it to the patient. We have the middle syringe is an empty syringe, has nothing in it. We're collecting the sample with that syringe. And then the syringe on the right is some flush so that we can flush the catheter when we're finished with a procedure. So here is a short of us collecting. This is obviously a back leg of a cat. So we're starting collecting from this scavenge sample. So this is the syringe with 0.5 ml of heparinized saline in it. We're filling this 3 ml syringe of blood from that catheter so that we're hopefully confident now that we've got fresh blood at the hub here, and we don't have saline or LRS or anything sitting in the catheter. Collecting the actual sample from this, this is a 20 gauge medial saphenous catheter in this cat.
Bleeds well.
Pulling out the actual sample, and hopefully that video is playing okay for everyone. And then that's obviously, we're going to use that sample for the tubes. And then the main point here is that original scavenge sample, you just need to make sure you keep that clean. So it has anticoagulant from the heparinized saline. You capped the needle and you've kept that clean, then you can safely reinfuse that sample so the animal didn't lose more blood than it absolutely had to. And then after that, you would flush your catheter. So catheter aspirated samples, I think, does make blood sampling much easier. All right, so I'm going to talk about 3 cases today to just try and hit some of the highlights. And there's a lot of things that I'm not going to touch on in the time we have, but some highlights that from an emergency room sort of perspective, I think that show the utility of a venous blood gas, and hopefully people find them valuable. Our first case is little, oops, there we go. Hopefully I think I clicked the wrong button, but I think we're good. First case is Baxter. He's a 12-month-old male castrated Labrador, and you'll be, very unusual presentation. He's vomiting for the last 24 hours, as a good Labrador will. So we've taken a venous blood gas from Baxter, and on this machine we've got quite a lot of values here for us to look at. There's a lot of numbers here. So what I've done is just taken the numbers I wanted to talk about today for him and put that in a table that's a little bit easier. So the blue numbers here are the values taken from his venous blood gas at presentation before any treatment. I have provided you a reference interval for those numbers to compare to. So 1.4, true for all blood work, but because blood gas machines don't routinely come with animal-specific, species-specific blood reference intervals, one important point is that you do need that. So dogs and cats have slightly different reference intervals. If you're managing animals that are not dogs and cats, they could have very different reference intervals. And so really important that you use an appropriate reference interval. And there's 2 studies that I use routinely. The second one is one we did at our own institution in cats. The first top study is a excellent study that shows reference intervals in dogs. So unless you're going to develop your own reference intervals in-house with your machine, I would strongly recommend you use studies like this that have looked at a good number of animals and developed those for you. So need a good reference interval to allow this comparison, because we're going to obviously decide whether we've got abnormalities based off that. So before we talk about Baxter, I do want to touch on acid base, which is an enormous topic, and I'm not going to spend very long on it. So this is, I don't want anyone to sort of tune out just because I've said those words. But I do think acid base has amazing diagnostic potential, and it isn't very hard. What we need to be able to recognize is straightforward. So I just wanted to share with you what I think are some key points to if you don't do acid base, to pique your interest, because I think it's easily, people get off put because it sort of seems intimidating or or unnecessarily complicated. But there's a version of it that's really, really useful at the bedside of an animal that has some sort of life-threatening abnormality. I think the key point for acid-base is if you can remember that the pH of the patient, which is the concentration of hydrogen the pH of that sample is determined by the ratio of bicarbonate to carbon dioxide. And then I'm going to just go through, as we go through some examples, highlight how that ratio really answers the questions we need to answer when it comes to clinical application of acid-base. So again, I'm not going to go through a full acid-base tutorial here, but it is just how I do acid-base is that I take the sample values, I take a reference interval, and just write down beside the pH, is it normal? Is it low, acidemia, or is it high, alkalemia? I then write beside the bicarbonate, is it low, metabolic acidosis, or is it high, metabolic alkalosis? And then I write beside the CO2, the partial pressure of carbon dioxide, if it's our respiratory component, if it's high, that CO2 is an acid. If you forget, just high CO2 increase or decrease pH, that ratio always answers that question. pH is determined by the ratio of bicarb to PCO2. PCO2 goes up, pH would go down. So we're going to label the CO2 as whether it's high, acidosis, normal, or low, alkalosis. And then at the end of the day, we're going to decide which system, the bicarbonate metabolic system or the CO2 respiratory system, is causing the abnormality in the pH that our patient has. So going through an example, I think, really is the best way for us to utilize this. So if we look at Baxter, he has, like I said, these are some of the numbers off his venous blood gas that I've got there in blue. So let's first just look at his acid-base status. His pH is actually quite high, so that's an alkalemia. His CO2, his carbon dioxide at 69 is high, so the respiratory contribution to his pH is an acidosis. High CO2 acts as an acid in the body. And his bicarbonate, his metabolic system is very high as well, so we've got a metabolic alkalosis. So they're quite an abnormal acid-base balance. So good thing here is if we've got an animal where there's any doubt about, gee, I wonder what's going on, this is probably going to help us get to it. He's got something wrong. He's not just, a boring case that we can ignore. This is quite abnormal. So we've already flagged an animal that probably needs more attention than if he didn't have those changes. And then potentially these changes could help direct what our next steps are diagnostically. Our next question now that we've labeled what the pH is, we've labeled the CO2, we've labeled the bicarb, is the disease is defined by his pH. So his disease is an alkalemia, it's acid-base world disease. A respiratory acidosis can't cause an alkalemia. That can't be the cause of that change in pH. And so the abnormality, the disease he has here is a disease that's generating a high bicarbonate, a metabolic alkalosis that accounts for his high pH. So that's our sort of primary abnormality, and likely that carbon dioxide being high is a compensation, it's a response to the abnormality. But the abnormality is defined by the pH. So his acid-base diagnosis is a primary metabolic alkalosis. Why do we care? Well, once we have an acid-base diagnosis, it takes you to a relatively short rule-out list, especially metabolic alkalosis. There's not many causes of metabolic alkalosis in dogs and cats. When we think about a metabolic alkalosis, we really always, it's treatable for all acid-base abnormalities. There's sort of always two ways to get there. For metabolic alkalosis, you either could have lost acid out of the metabolic system, so that you've got too much base, too much bicarb, or you've added bicarb in. Because our animals are carnivores, dogs and cats, they don't really have any natural causes of a true bicarbonate gain. And so that's really a rule out for something that iatrogenic, that we've administered too much bicarbonate. So for an animal in the emergency room like Baxter, we're really looking for a reason that he's lost acid out of his system. And he has two possibilities here. He could have lost it through his stomach or through the kidneys. And through the kidneys, probably the most common mechanism is animals we see on high-dose furosemide, so not relevant to Baxter. Obviously, he's a vomiting dog, so the loss of acid through his stomach makes a lot of sense. One thing to keep in mind is that if you did blood gases on, venous blood gases on every vomiting animal, the vast majority you see will not have a metabolic alkalosis. The normal vomiting reflex, it refluxes small intestinal fluid from the proximal duodenum up into the stomach, and that fluid is full of bicarbonate from the pancreas, and then there's gastric acid in the stomach, and then that animal then actually vomits and loses that fluid, and so they lose both acid from the stomach and bicarbonate-rich fluid from the small intestine. So it's a fairly acid-base neutral event. So the average, Labrador that eats something disgusting in the park and comes in vomiting, I would not expect him to have a metabolic alkalosis. When we see a metabolic alkalosis, and this is a pretty substantial one in Baxter, it really means he has some reason that he's able to lose acid from his stomach, but he's unable to lose the bicarbonate-rich fluid from his small intestine. So strongly suggests that at least at some point, he's had an obstructive process in that pyloric outflow obstruction or proximal duodenum that has allowed that selective gastric acid loss. And so, I'm not a believer that we need to image every animal, every vomiting Labrador that comes into the emergency room. It's, I just don't think that's practical. And it's a very, very common presenting complaint for, a 12-month-old Labrador. But if I see a metabolic alkalosis like that, I think that is a dog I would really emphasize imaging to the owner, that this animal, at least at some point, has had probably a physical obstruction. Now, sometimes they can move on their own and it's resolved by the time we're evaluating them. But if there's any doubt, in the clinician's mind or the owner's mind, I would be pretty forceful about the need to image this dog. And Baxter had eaten a lot of fabric that had created a pyloric outflow obstruction. So acid base really can be straightforward. And like I said, when you've got a significant acid base abnormality, it really reassures you as a clinician that a problem I probably need to know about. Like, if I don't have a disease on my rule out list or my understanding of this animal that accounts for that acid base abnormality, and I'm missing something, I need to go look for that. And then obviously the more severe an acid base abnormality, potentially the more concerned you'd be about the status of that patient. Next little patient I wanted to tell you about is Moose. He's an 8-year-old domestic sort of longish-haired cat. And he's also been vomiting for the last 24 hours. And he presented on physical examination relatively uneventfully, other than he was a bit dehydrated, but probably nothing that really stood out on our physical examination about Moose. We've collected a venous blood gas on Moose, and again, have a lot of values here, and I'm not going to go through them all, but a lot of great information that we're able to get, like I said, within minutes on him. And so when I'll highlight some of the numbers we're going to talk about on Moose here in the blue, we can see he's got some clear values out of the reference interval. If we start with acid base, because of Moose, I think that is a really relevant piece of his puzzle. We can see that he's got a very low pH, and I would say as I've gone through my career, I'm less and less concerned by the actual pH, like a pH of 6.9. I showed you the photo of that cat. He's sitting up looking at you. It doesn't necessarily in its own right, this pH of 6.9 is not going to kill you. But it is the disease that causes that pH that's the problem. And so it's obviously a very severe disease. Something really bad has to happen for your pH to get that low. And so again, it flags an animal that, if you're doing a triage, I've got a few animals here, they all look about the same, and one has a pH of 6.9 and the others don't. I'm probably going to look at that animal first. I think this is an animal with a really significant sort of metabolic derangement. When we look at his carbon dioxide value, it's low, so he has a respiratory alkalosis. but that bicarbonate's very, very low, so it has a metabolic acidosis. And so again, when it comes to saying what's the acid-base abnormality moose has, a low pH and acidemia, in this case, has to be due to metabolic acidosis. A respiratory alkalosis is helping us. It's trying to prevent the pH being as abnormal as it would be otherwise, but the disease is the metabolic acidosis, which is driving his pH so low. So metabolic acidosis is the sort of most common acid-base disorder that we see in sick patients generally. They tend to be a metabolic acidosis, so a very common finding. But the good news is I do think it can really get you sort of narrow down your rule-out list, because it boils down to a handful of pretty common diseases that will create a metabolic acidosis. One thing we look at when we see a patient with a metabolic acidosis is their anion gap. Lots of blood gas machines will actually, you can ask them to calculate it for you, but otherwise you can hand calculate it if you have all the values available. So it's very simple formula. It's the major cations, sodium and potassium, minus the major anions, chloride and bicarbonate. The reality is that there are some other anions in the system, albumin and phosphate in a healthy animal, that the anionic charge on those are not so easy to quantitate as it is to look at a chloride or a bicarb concentration. So over the sort of by convention, we don't try to measure those directly, and we just estimate the charge on those unmeasured anions by this formula called the anion gap. So there's no gap, it's just there's anions in the system we're not accounting for in this formula. Why do we care about the anion gap? It's to try to narrow the rule-out list to say, why does this animal have a metabolic acidosis? What are the things I should be focusing on? So metabolic acidosis comes in two flavors. It's the metabolic acidosis we see that develops with a high anion gap, and the metabolic acidosis that can develop with a normal anion gap. And that rule-out list, like I said, is fairly short. Normal anion gap metabolic acidosis really implies that bicarbonate was lost from the body. And so in dogs and cats, that's almost always going to be a renal mechanism. Diarrhea, secretory diarrhea, you can lose a lot of bicarbonate. It's not a common form of diarrhea in dogs and cats. That's more a sort of calves and, baby ruminants and things like that. So it's really not a feature for small animal medicine. So normal anion gap metabolic acidosis, we think about renal dysfunction. The high anion gap metabolic acidosis, we think about an acid's been added to the system. We've got an abnormal acid accumulating in the patient. And the four most common mechanisms that we see, I use the acronym JUL to remember, which are the keto acids, uremic acids from acute kidney injury, ethylene glycol from an intoxication, and then, of course, lactate and lactic acid. Now, there are lots of other things out there that could possibly cause a high anion gap metabolic acidosis, but they're very uncommon. But if you ruled these four out and you've got an animal with a high anion gap, many of them are other toxins. You just go to a textbook, Google, and start looking for other causes. But they're, like I said, very uncommon. One comment I'll just make as an aside, there are scenarios where the anion gap, where an animal could have one of the dual mechanisms and not have a high anion gap. And because it's not a perfect parameter and it has quite a wide reference interval. So, I'd keep a little bit of an open mind. If the animal has a normal anion gap, I'd probably do due diligence, just think about dual and then I'm not missing something. If you have a venous blood gas with lots of the parameters on, that's very easy to do to rule out the others. If you've got a high anion gap, it's high, and that really is diagnostically, there's going to be something abnormal in the system of that patient that our job is to find. So looking at Moose, he's, like we said, he has a metabolic acidosis, and right at the bottom of that table, his anion gap was 40. The reference interval was 15 to 20. So it's actually quite a high anion gap metabolic acidosis. So we've got the dual to look at. He's lactates out of the reference interval, so that's a contributor. But animals often have more than one of these high anion gap metabolic acids in their system. So don't just find one and stop there. So a lactate of 3, it's not a very big lactate, and we're talking about an anion gap of 40 and a bicarb of 5. So there's more acid in this animal than just a lactate of 3. It's a very small, that's a very small change in lactate, and an animal does not account for the severity of his metabolic acidosis. Now, his glucose of 438 is interesting, of course, because then it raises the question of whether this could be an animal that has ketoacids. And then the other one, which we often see in sick animals, especially sick cats, would be uremia, and whether uremic acids are contributing. But interestingly, in this cat, his creatinine is normal. So I don't think uremia is going to be a feature for him, but he's definitely got a little bit of lactate. And I want to know whether he's got ketones, and doing a urine dipstick, we can quickly ascertain that he's very positive for ketones, and so he's a cat with diabetic ketoacidosis and a small amount of lactate. I think that having all these values on, again, a tiny sample of blood and 3 minutes, and we can assess his kidneys, we're assessing his lactate, we can see whether he could be a DKA. I think, is pretty powerful, and we quickly can, be talking to that owner about the next steps for Moose. Moving on to Star, she's a 10-year-old female spayed border collie that's been vomiting the last 24 hours. And then this morning really didn't want to get out of her bed. And so the owners brought her in to us. And you can see that, she certainly does not look like a well dog on presentation. Her temperature's a little bit low. Her heart rate's higher than I would expect in a dog of her size. And she cardiovascularly does not seem to be normal. Her pulse quality is suboptimal as well. So part of our stabilization, so our routine sort of approach to an unstable patient like this will be to place an IV catheter, and we will aspirate a blood sample from that catheter before we hook it up to anything. And then as soon as we know an owner's agreeable to us proceeding with diagnostics, we'll run that venous blood gas. And so for Star, we've got our venous blood gas on her. Again, lots and lots of numbers, a little bit hard to read on the screen. So I've just put some of the key numbers for her into a table. So this is some big numbers that jump out on Star. She has a pretty low pH at 7.071. She has, her electrolytes aren't too exciting, although her potassium's getting up there at 5.8. I think her glucose is low and her lactate is very high. And we have an anion gap on Star as well. So my approach for a venous blood gas, when usually somebody hands me one, we're looking at a sick patient, I get handed the venous blood gas, is a quick screen for the things that I think could kill an animal very quickly. And I think that the sort of, and as much as I love acid base, it's generally not going to be the acid base. So I'm going to do a quick screen down there to make sure there's nothing that I should be doing in the next 2 minutes, and instead of still reading the blood gas. And so I think the glucose is definitely the number one thing I would look at in a compromised animal. If this animal's hypoglycemic, I need to intervene. I think potassium is the other one. They're the two of the big ones I would sort of my eyes go to. I think the third one would be that on our blood gas, we also get, I think if I can, on our blood gas, and we can see it up here, but under the oximetry values, we get a hemoglobin concentration. And so we can pick up animals that have significant anemia. And so that initial 5-second screen is like, is the glucose okay? Is the hemoglobin okay? Is the potassium okay? If none of those need me to do something in the next 5 minutes, then I'll stop and go back through in more detail the rest of that animal's blood gas. So obviously the Star, that glucose is at the standout number here as far as something we could do that will impact her outcome long term. Before we move on, just the order of my slides here, before we move on, I'm just going to touch on her acid base status, but we will talk about her glucose more, and I would not be looking at her acid base status before I'd fixed her blood glucose, just in case anybody thinks I'm that passionate about acid base. I do have some rules. So Star, when we look at her acid base balance, her pH is very low, so she has an acidemia. Her CO2 is actually higher than the reference interval, so that's a respiratory acidosis, and her bicarbonate's quite low at 13, so a metabolic acidosis. So the other two examples I showed you, only one of the systems, respiratory versus metabolic, were the cause of the change in pH, and the other system was probably compensating. This is a situation of what we would call a mixed disorder, where that low pH is due to both an abnormal respiratory contribution, the respiratory acidosis, in addition to the metabolic acidosis. So she has two contributors to her acidemia, and certainly likely to give her a pretty severe acidemia. You don't have that benefit of compensation. So she has two acidotic processes going on. You know, respiratory acidosis is interesting. When we did a study looking at sort of the most common acid base abnormalities in animals in the emergency room, we actually saw respiratory acidosis was actually the most common abnormality that we found. And so I just wanted to touch on that, because one of the important comparators here is that this whole conversation is about venous blood samples, which really is, you know, in veterinary medicine, the vast majority of blood gases we do are in venous blood samples. Now, there's a huge role for arterial blood sampling, and it's another amazing sort of application of a blood gas machine. But logistics in small animals and compromised animals in the emergency room is that we're rarely going to start with an arterial sample. So you have to be a little bit careful when you look at some of the human literature on blood gas analysis and use, because their majority of their literature is going to be talking about arterial blood gases. More recently, they're starting to talk about the fact that there's a value in venous blood gas analysis, but it's not been the standard approach in human medicine. So just sort of a warning there if you're looking at their literature. So when we see a change in CO2 in the venous system, we have a little bit of a different discussion than when we see it in the arterial system. A increase in carbon dioxide in venous blood has two rule outs. If this was an arterial sample, there would only be one rule out. So one scenario is that animal is not ventilating, which means not moving fresh gas in and out of its lungs well enough to control CO2, so hypoventilation. And that will mean that the CO2 accumulates and we get a high CO2. And that's certainly true, a good mechanism of high venous CO2. Remembering that in health, venous CO2 is only 4 or 5 millimeters of mercury higher than arterial. So in an animal that's cardiovascularly stable and healthy, a venous CO2 really does make you worry that the arterial CO2 is also high and that this patient has hypoventilation. Once we're talking about animals that are hemodynamically unstable, which our patient Star here is, then this is a slightly different, there's another concept here, and that is that hemodynamic instability, the venous CO2 may no longer tell you what the arterial CO2 is doing, and the venous CO2 could be high just because of the poor perfusion and that blood sort of sitting in the periphery a long time, picking up a lot of more CO2 than it normally does. And so we really can't confidently say what the ventilatory status is for Star. So that dog has got poor perfusion on physical examination and an increased venous CO2 on our venous blood gas. Could she be hypoventilating? It's possible, but this could easily be due to poor perfusion. And so my approach would be to treat her perfusion abnormalities. And if there's any reason to suspect hypoventilation after you've resuscitated the patient, then, and that's probably going to be, but, if that were neurologically abnormal or something, then I'd recheck your venous CO2 and make sure that it's improved with resuscitation. But it's very common in unstable emergency room animals for their venous CO2 to be high, and most of them probably do not have hypoventilation. It's probably much more a reflection of their cardiovascular status. If we have patients with a low CO2 on our venous blood gas, remember that arterial is always a value lower than venous, then we have diagnosed hyperventilation by definition, and we know that that's true on the arterial side because it's a number even lower. So low CO2 on a venous blood gas only has one rule out, same as arterial blood gases. That's hyperventilation. Increased carbon dioxide on a venous blood gas has two rule outs, and again, really interpret that in light of your physical examination assessment of that patient's hemodynamic stability. All right, so going back to Star, she has both a respiratory and metabolic acidosis. We are going to assume the respiratory acidosis is secondary to her poor perfusion at this point in time. Looking at her metabolic acidosis, her anion gap right at the bottom table there at 24 is higher than the significantly higher than the interval. So this is a high anion gap metabolic acidosis. And thinking about our dual, obviously her lactate of 12 jumps out. And unlike the previous case, the cat, her lactate 3, that really wasn't enough to account for the severity of that metabolic acidosis in the cat. A lactate of 12 is a very severe lactic acidosis and would create a significant increase in the anion gap and a significant metabolic acidosis. And so I think the lactic acidosis here is a major player. But the beauty of a blood gas like this is that, these animals can have more than one disease. We can quickly check, is she a DKA? No, she's got a low blood glucose. Is she uremic? Have a creatinine on her in the reference interval. So this is not uremic. Her potassium is such that you would be good to ask that question. But that's one of the nice things about a blood that gives you lots of parameters, is that you can not just get sort of, I just went down the lactate road and I totally missed that she also had a DKA or also had acute kidney injury. You can rapidly look at those values on your blood gas and just rule them out. So for Star, we really felt we had a dog that had a lactic acidosis as a major acid base abnormality and hypoglycemia. Hypoglycemia, obviously not good for the patient, but as a clinician, I love finding hypoglycemia, and that's because it leads you down the path of a really short rule out list. It really gets you to an answer, I think, in many patients much more quickly, because we just don't have that many causes. And by the time you have history, signalment, physical examination, and hypoglycemia, you're usually pretty close to a diagnosis for that animal. Of course, anything less than 80 milligrams per deciliter we would consider as a low blood glucose. We're probably not seeing overt clinical signs until they're less than 60. Human medicine sometimes says less than 50, but somewhere in there. So I think any low blood glucose warrants immediate therapy of some sort, but sort of, I think the lower it is, obviously, the more, giving IV dextrose quickly is going to be sort of your primary go-to. When we think about reasons for an animal to have hypoglycemia, this is not every reason on the slide, but I think this is the majority. I think the two things we have to think about are the neonates and the toy breeds. So neonates of little baby puppies and kittens and toy breed dogs can often don't have a competent liver, so they don't have a lot of glycogen stores, so they can't maintain blood glucoses if they're inappetent in many situations. So when you've got little tiny dogs or babies, having a low blood glucose could purely just be secondary to just being sick and not eating as much as they should have in the last 12 hours. So it may not have sinister implications. It could purely just be sort of a part of the physiology of that little animal. Once we're talking about larger breed dogs, so something that a non-toy breed dog and cats that are I don't know, 6 months old, probably over 4 months, but 6 months to be sure. Once they're sort of, developing adult physiology, inappetence, not eating, is not a mechanism of hypoglycemia. They have amazing livers, and not eating for long periods of time, you will not generate hypoglycemia. So, it's easy to sort of say, well, the owner said he hasn't eaten for 3 days. Maybe that's why he's got a low blood glucose, and, I'm going to have to go somewhere else to find my diagnosis. You've got an adult Labrador and he's, or Star, and she's hypoglycemic, and she could have not eaten for 2 weeks. She has a disease that's causing that hypoglycemia. So if it's not a neonate, it's not a toy breed, then what are we thinking about? Obviously, a known diabetic that's receiving insulin, it's likely to be something to do with insulin overdose or getting insulin without eating or something. So that's usually clear from your history. Then we're left with diseases, sepsis, hepatic failure, and this really has to be failure. The animals that get hypoglycemic from liver disease, it's the last sort of synthetic function the liver will maintain to the very end. So these animals would be very overtly like icteric. They would have, very abnormal blood work. This would not be a subtle finding of hepatic disease. Insulinoma, certainly we know, middle-aged, these are usually middle-aged, very healthy appearing animals. They often have a history of sort of intermittent ataxia. They classically look amazingly well for a very low blood glucose. So they, unlike Star, who's collapsed with her blood glucose of 33, they may walk in the door with a blood glucose of 33 or 40. So they sort of look a little bit interesting, but when we rule out other things, they're definitely going to be on the list. Remember, there are other cancers that can produce insulin, like factors that also can present sort of in a similar way. Addison's, hypoadrenocorticism, 20 to 25% of dogs with Addison's have hypoglycemia on presentation. So always an interesting finding in a dog for sure, to make sure that no other obvious reason that might be something we have to work up. And then, of course, xylitol intoxication in a dog, if the history was compatible, that would obviously be a reason as well. Treatment-wise, I think, probably everybody's aware of that, but I think just giving intravenous 50% dextrose really is ideal. I think that the transmucosal, like putting dextrose or caro syrup or something on the gums, is not what I wouldn't do in the hospital setting unless it just couldn't get vascular access or there was some reason why, it's a financial thing. I think at home for an owner, that's great, but it can take 15 minutes or more for that to reach blood levels of increased glucose. So I think if you've got an animal that really has serious hypoglycemia and you can get IV access and you've got IV dextrose, I really think you should be doing IV and don't rely on the transmucosal application of agents. I would say that, a little puppy that's like a little neonate or toy breed that's hypoglycemic, you give it some dextrose, it wakes up and eats a bowl of food, I'm probably not going to recheck its blood glucose. But a sick animal, these doses of dextrose we give are very arbitrary. They're not, so you don't actually know what that's going to do for the blood glucose of that patient. So just recheck it at some point and make sure you have actually reached a normal range in blood glucose in that patient. And then, of course, animals that have ongoing disease processes might need to have ongoing dextrose supplementation, depending on the situation. So we look at Star, she's got a pretty severe lactic acidosis, so she's in shock, and she has hypotension and hypoglycemia. So she did with blood, her mean arterial pressure is 49, so we think she's both hypovolemic and hypotensive. She's screaming sepsis, and I think really any animal that has hypoglycemia and any evidence of an infection, which Star's not showing very many signs because she's quite compromised, but fever would be a classic if they're well enough. But Star was, maybe this dog was actually, I'm sorry, maybe she was febrile, I can't remember now. But poor perfusion, that sort of set of findings is, I think we should assume is sepsis until proven otherwise, because we know that early appropriate antibiotic therapy and potentially, control of the source of the infection really will increase survival dramatically. So it's much better to assume the worst and treat that animal as a septic patient. And if we find out we're wrong and it had Addison's and I gave it a whole lot of antibiotics, it's not not the end of the world. But if we find out the next day it's not Addison's and it was sepsis, we've probably missed the window to save that animal. So really be, I think, have sepsis sort of the forefront of your mind for an adult animal that's hypoglycemic and looks sick. Star had septic peritonitis, so on point-of-care ultrasound, we quickly identified that she had free fluid, which we collected, and on cytology saw intracellular bacteria, so certainly accounts for her presentation. Another use of your blood gas machine, and I guess maybe you have to check whether all blood gas machines will do it, but certainly many of them, you can put abdominal fluid or put body fluids in the blood gas machine. I don't always tell the blood gas machine people I do that, but it does. Usually you can get values for lactate and glucose, or you can use handheld lactate meters and glucometers. But there is evidence that your animals with septic effusions, septic peritonitis in dogs, at least, that you can find some supportive evidence for that from comparing the glucose in the fluid and the lactate in the fluid with the blood glucose and blood lactate collected pretty well at the same time. So this is not from Star, but this example on the slide was a dog with septic peritonitis whose blood glucose was 92 and blood lactate was 0.8. But the abdominal effusion collected at the same time had a glucose that's it's 51, so quite a bit lower than the 92, and a lactate that's quite a bit higher at 4.7. So very consistent with septic peritonitis. This is not a finding that I would not go to surgery if this was the only evidence I had for septic peritonitis, but it's some of these animals where the diagnosis is not as absolutely clear as some, and this does help push you towards saying, "Ooh, I really am worried this is a septic abdomen." There isn't much information on cats, and so it's not as proven that this is as diagnostically useful in cats, but we do have some good studies in dogs that show that this is usually a fairly consistent finding. Sepsis, obviously, we're going to, just a reminder that we are going to focus on that in patients that have cardiovascular instability and hypoglycemia. They're really the sort of hallmarks of a sick septic patient. We're going to, getting an early blood glucose on sick animals is well worth it. Looking at the time, I don't have a lot of time. I think I might just make one last little quick comment about the venous oxygen. So I just one comment I wanted to make is that arterial blood gases are the gold standard for monitoring oxygenation, but just that venous oxygen, we can't use that to monitor like lung function and oxygenation. So you can't look at a venous blood gas, look at the oxygen and say, oh, he's got pneumonia and he needs oxygen therapy. You can't do that. But there are some really interesting things you can say from looking at venous oxygen. Venous oxygen is what we call a downstream parameter. So it's going to be the product of how much oxygen did you deliver to the tissues minus how much did the tissues use, and now what's left over is your venous oxygen. And so from that, it's usually pretty obvious that if we see an animal with low venous oxygen, that's either because we didn't deliver enough or we consumed too much. And in clinical medicine, it's nearly always going to be a product of oxygen delivery. So animals with low venous O2, where, like I said, we're really going to focus on decreased oxygen delivery. The increases in oxygen consumption that we can see with something like fever just usually aren't quantitatively significant enough to be a major player. So decreased oxygen delivery, the three big contributors here would be cardiac output. So something like, is that animal hypovolemic? And that's why we're getting poor oxygen delivery. Oxygen content could be low. So is that hypoxemia? So maybe does have lung disease, does need oxygen. So that's a potential mechanism of low oxygen delivery that could leave you with low venous oxygen. And anemia, which is probably one of the big ones we see, it doesn't matter how well you oxygenate the blood if you don't have enough hemoglobin to carry that oxygen to the tissues. So all things that we would look at in a patient that had low venous oxygen to try and determine which one or maybe more than one that individual patient may have. quantitatively, cardiac output has the biggest impact on oxygen delivery, and so it's always the sort of first thought when we see low venous oxygen: is this an animal that needs shock resuscitation? But obviously, we also, you can see animals that have severe hypoxemia or anemia. I would say just some values: normal venous oxygen's in the 40s. There is a role for venous oxygen has been shown as a resuscitation endpoint, meaning you have a patient that's in shock, maybe it had a low venous oxygen, you do some fluid therapy and you're wondering, I think he looks better, I wonder how I'm doing. One marker of resuscitation is that you've increased your venous oxygen. And then low venous oxygen, when do we say, oh my God, this, we got to do something, seems low? It's usually when their values are under 30. And so just one scenario that we use it for when we're looking at IMHA dogs, and when should we transfuse a dog with IMHA? Because they often don't like their transfusions, it can be hard to get a compatible transfusion for an IMHA. We're less proactive at transfusing them than other patients. And so looking at the venous blood gas in these patients can be very valuable. So here's a little IMHA dog whose hemoglobin is only 5.3, so it's very anemic. Does he need a transfusion? Maybe. Lactate is 0.9, venous oxygen is greater than 30. If we didn't have a very compatible blood transfusion available for this guy, I'd probably wait. I think he's probably going to do okay. If clinically he seems like he's stable, I would hold if I had to on that little dog. In contrast, this little dog, hemoglobin is lower at 3, lactate is 3.9, venous oxygen is less than 30 at 26. I think we have to transfuse this dog, even if it's not the best transfusion. That this is telling me that cells in the body probably didn't get as much oxygen as they wanted. So the venous oxygen can be really nice as a marker of oxygen delivery and as a therapeutic monitoring agent. So with that, I'll wrap it up. I think the venous blood gas really is one of the most valuable tools at our disposal, and I think that one of the really nice things is the diagnostic power and then the monitoring power. Like, are those parameters getting better? That means I'm giving them the right, my treatment plan is working. Do I need to change something? And so, like I said, many animals in our hospital are getting multiple venous blood gases in a period, so that we can actually mark the progress of that case and make sure we're tailoring our therapy accordingly. I'm not sure how we're doing for time. It looks like I've taken up a bit of extra time, but are there any questions there that we've got time for?
Not a problem, Kate. I want to thank you for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located in the lower left corner of your screen, and we'll answer as many questions as we have time for. All right, let's go ahead and get started. Our first question asks, how do you minimize stress and trauma to the animal during blood collection? Any specific techniques between large and small animals?
The question is minimizing trauma for blood collection. Was that the question? Yeah, I think I'm not the right person to ask you about for the large animals, but I can for small animals. I think the big thing we rely on in animals that aren't a bit unhappy would be using back legs and not front legs, and I feel like they often are less intimidated. They'll someone can be being sort of settling and gentle with them at the front end, and we can get something from a back leg and not stress them as much. Or if they're really getting themselves worked up, we're sedating them first. So something like, depending on their disease process, a mu opioid or butorphanol or something, just giving them a little bit of time to chill out and then getting the blood sample after that. It would really depend, obviously, on how critical they are. But I do think avoiding the front end sometimes is nice.
Excellent, thank you. All right, our next question here asks, what are the best ways to collect venous blood gas samples? Syringe, microtube, cap?
Yeah, that's a great question. I think the one thing that to keep in mind, really it does depend a little bit of what values you're most interested in, but if you collect into regular blood tube, so that vacuum, green top tube. Depends on your blood gas machine, but generally they want a heparinized sample. It has to be heparinized at some point. So you do have to think about if you put too much heparin in, liquid heparin will dilute out the sample. Dry heparin won't dilute it out, but dry heparin will bind ionized calcium and ionized beta, can affect those results. So getting the right amount of heparin is important. So if you're going to use a tube, you can, because the tube is open to the air, whether that's a vacuum tube or just a tube you take the top off, you can alter CO2 levels, and that can change your acid base stuff. So in a perfect world, I would not collect samples into a tube. I would collect it into a closed syringe. And so your options to either heparinize the syringe, and you can do that yourself, or you can buy pre-heparinized syringes. And I would be using a 1 ml syringe. We don't need very much blood. Or you collect the blood in a syringe with no anticoagulant, a naked syringe, 1 ml syringe, and then you transfer that to a heparinized, looks like a sort of hematocrit type looking tube that's purpose made for your blood gas machine. So what equipment you use will depend on the blood gas machine. But the machine we buy pre-heparinized, like I said, they look like a large PCV tube. And so we take uncoagulated blood, non-coagulated blood straight out of the patient, and we fill those little tubes. And that way we use the least amount of blood. We cap the ends. It's not exposed to air. But I think the main point there is be careful of over heparinizing, and ideally have in a sealed system so it's not exposed to the air.
Okay, wonderful. Thank you. Moving on to our next question here. This question asks, how frequently should VBGs be repeated in a critically ill patient to monitor progress?
No, it's a great question. I don't know that there's one answer for that question. I do think that the really critical ones, like that dog star, I would say could easily get 2 or 3 in the first 1 to 2 hours of stabilization. That initial emergency room, sort of what's wrong, making that dog stable, and deciding whether how the owners are going to go forward. One thing to think about is once you do fluid boluses, like let's say that animal needs sort of shock resuscitation, is I would try not to do another venous blood gas like 2 minutes after you give your shock bolus, because that initial bolus, let's say give a liter of fluids, will be all in the intravascular space and really dilute out a lot of your hemoglobin and things. But in half an hour or so, it'll have redistributed, and only sort of 25 or 30% of that volume will stay in the vascular space. I think it would be ideal, if you can, to wait and sort of 20 to 30 minutes after you finish your bolus before you recheck, so that you don't get sort of a slightly diluted version of where that animal's going to stabilize at. One thing I would say though is if you're worried the blood glucose are low and you need to recheck it, then you shouldn't wait half an hour. So that would be the caveat to that. But yeah, I think I do it at presentation, and then I'm usually going to do it sort of half an hour after the initial resuscitation. And then it's going to depend. If the potassium's high and I'm going to have to actively treat that, they could then be getting venous blood gases every 2 or 3 hours for the next sort of time until the potassium is normalized.
Wonderful. Thank you. Okay, our next question here asks, what are the biggest species to species variations in VBG interpretation, cats versus dogs?
Oh, good question. So the biggest one is not cats versus dogs, is carnivores versus herbivores. But if you're just doing cats and dogs, the big one is that cats tend to have their sort of a normal cat looks like it has a bit of a metabolic acidosis compared to a normal dog. So a normal cat, just because they're obligate carnivores, and so the more protein you eat, the more acid you make. And so their bicarbs sit a little bit lower than dogs will sit. And then their CO2 levels also sit a little bit lower. So they have, a relative respiratory alkalosis compared to dogs. So dogs are similar to people, slightly lower bicarbonate than people, because they're a bit more carnivorous than the average person, and cats are more have more of a metabolic acidosis than that. So it's not enormous. But I think for acid base is the main differences. I think for most of the other values, it's not as major, the differences. So I think if you only had a dog reference interval, you would be okay in most situations for cats. But I would not use a human reference interval or a non-dog or cat reference interval.
Okay, great. We're going to squeeze in just a couple more questions here, so we appreciate your patience. This next question says, most of the more comprehensive blood gas analyzers can report a total hemoglobin and other hemoglobin-related parameters. Which ones do you routinely use and why?
Oh, great question. I think the number one thing I use is the total hemoglobin. Like, remembering that your packed cell volume is approximately 3 times the hemoglobin concentration. Like, we just live off that value because it's faster than the PCV spinning. And so, I think it's excellent. If anyone's, I think you'll be a little bit more careful, depends on your machine. Like for us, when we get into some of the large animal species, that hemoglobin reading is not as consistent, but in dogs and cats, it's that total hemoglobin has been excellent. I don't use the hemoglobin saturation that we get from, and again, it depends how your machine does it. If your machine calculates saturation from the partial pressure of oxygen, that's a fairly reliable number, a little bit, but remember, it's all based on human algorithms, so it's not exact. Once you're talking about machines that have co-oximeters that measure saturation from a co-oximeter, unfortunately, dog and cat hemoglobin doesn't look quite like human hemoglobin. You can get slightly wacky values. So I would just use your partial pressure of oxygen. It's more accurate. It's perfectly accurate. The other thing that's great, and we had one yesterday, is that if you have a machine that gives you hemoglobin and carboxyhemoglobin. I had a smoke inhalation dog last month with carboxyhemoglobin, had carbon monoxide toxicity. It was fantastic monitor. We had a dog in yesterday with dog bite wounds, got raced to surgery because it had intra-abdominal bowel penetration, and on induction, it was like the bluest thing anyone had ever seen. The pulse oximeter was a very low number. Everyone was like, oh my God, what's happening? Grabbed a venous blood gas. It had bypassed it. It looked so stable. It never got one. Note to self, we probably should have done one before. Anyway, it had a methemoglobin of 37%. So it is a congenital methemoglobin dog. So those values are not common abnormalities, but when you have them, it's sort of life-saving for us to say, oh my God, that's okay. We know why the dog was purple and it's not some other reason. So, but every day, all day, the total hemoglobin's the really valuable number there.
Okay, wow. All right, our last question that we have time for today. This one says, are there any parameters that you would use with caution or not use when drawing a venous sample as opposed to an arterial sample, and why?
Okay, yeah, I think that it's really the gases. And so I think it's really partial pressure of oxygen, PO2. I think the venous O2, like I said, has some really interesting applications. I think it's very useful. But if my question is, does this animal have bad lungs? Do I need to give this animal oxygen or more oxygen? Then you have to have an arterial sample. So the venous sample can't answer that question. So if I'm determining whether an animal needs to be admitted to stay on oxygen or I'm titrating oxygen therapy, I need an arterial sample for that. Carbon dioxide, I think it comes down to the many animals that we have that are hypoventilating, like a neck, a disc herniation in the neck, and the animal's paralyzed and can't breathe, but is cardiovascularly stable. Then we'll monitor their CO2s off of venous blood gas, because that venous blood gas is very close to arterial. As soon as we think they're hemodynamically unstable, then you would, if your question is, gee, is this animal paralyzed and does it need to be ventilated because he can't breathe, you would need an arterial blood gas to answer that ventilation question. So CO2, I would use either, as long as they're cardiovascularly stable. If my question is about oxygenation, it has to be an arterial sample.
Okay.
Everything else is totally interchangeable between arterial and venous.
Okay, great. Well, I want to thank you for your time today. We would also like to thank LabRoots and our sponsor, Radiometer, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.